Happy to see him here in Greece again.
Well, thank you, Ignatie. Indeed, classmates in medical school, not just in France for many years, and thank all the organizing committee for moving on with this Congress over the years and keep increasing the quality as well as the breadth of the material covered, obviously in parallel with what great advances have been achieved in the subject of transcatheter valve therapies, and obviously the cutting-edge therapies applied at IHEA for many years already. I have the chance to talk to you today about the leaflet thrombosis in bioprosthetic aortic valves. And we're going to go ahead initially to just show you some nice pictures of what this could look like. Really a subtle finding indeed. That's why I think not many people realize it even. We didn't even think about it until many years into the TAVR era. No matter how you can see and how great this image can be, you can understand and you can realize that this is a subtle finding, because if this is the top, if this is the best image from a very top imaging center, you can see that artifacts blooming from the stent and various other factors relating with the imaging protocol in the non-centers of excellence, run-of-the-mill, regular CTA scanners in radiology departments in all the hospitals around the world. They cannot produce these images very clearly. Hence, it's also a small finding and a subtle finding. And the mean gradient of this phenomenon is also on a range that doesn't strike anyone's eye as anything too important as well. The aspect of the bioprosthetic valves in general and the possible thrombosis has also, and this is from the surgical literature, has also another axis of confusion. The difference or the possibility between thrombus and panas. And if you look at the bottom left, now kind of seems a little obvious. The red thrombus, white and yellow not thrombus. Unfortunately, the CT scans, they don't have the color. So although in the pathologic sphere and imaging, you can say, you know what, how can you mess it up? It's kind of obvious. Unfortunately, in the non-invasive imaging, we really cannot see that difference, and hence we're always a little puzzled. Is it a reversible potentially thrombus, or is it more of an organized panas that has nothing to do? And interestingly, could the thrombus be the underlying mechanism that over time develops into panas? That's another aspect that we need to be attentive to. And you can see that the multivariate predictors of valve thrombosis in bioprosthetic world from surgical literature is really nothing too crazy. Includes the abnormal cusp mobility and the cusp thickness, very difficult aspects to measure, as we discussed already, and some other factors that increase thrombosis anyhow, or one could say they're associated with the need of anticoagulation anyhow, such as AFib and all that. So nothing really that can be a clue from clinical point of view. So going down and reviewing the pathogenesis of this problem, you can try to relate it in some ways into the stent thrombosis in the coronary and the endovascular field, and understand that there is an interaction of complex things, of surface factors, hemodynamic factors, or the hemostatic factors, and not every patient has the same pathophysiology and the same combination. At the same time, this thing is not going to develop out of a single factor in no patient. So you need to have some combination, but this combination sort of vary. The underlying pathology that escaped us in the beginning of the TAVI world, although you can see that this publication is over 10 years ago, and there was some maybe not so telling, but similar data maybe from a couple of years before this one, is that as the valve becomes stenotic, the native valve that is, the consistency changes. And it's not only calcium, but it includes a lot of this brown material that you see that is essentially stained for tissue factor. And if we know the pathophysiology of tissue factor is that promotes thrombosis, the most potent stimulus inside the body, the vasculature. So anything that can disrupt this stenotic valve all the way to the side, that's a leaflet, will release automatically the tissue factor in direct contact with the circulating blood, and it will cause thrombosis. There's no question about that. And interesting, the contrast is that in the regular valve, with the normal leaflet, that doesn't exist. So before this study, one could say that our understanding of the stenotic valve, well, there was a lot of calcium deposition and maybe some hyperplasia, but the same consistency. The fact there's so much tissue factor around, I think, was a surprise finding. And we have even some very recent data indicating that in the TAVI valve, intracatheter heart valve devices, there is similar aspects of propagating hyperplasia and clotting, or a combination of that over time. And you can see these pictures. And interestingly, there are other aspects you can see. Thrombus, more laminar, fibrotic, calcification, and you can see also the thrombus can be lamellar or can be more concentrated, papillary, unclear. Perhaps this could be related to maybe a local phenomenon, perhaps too aggressive or multiple post-dilatations, I would say. And you can also see how the normal thing could be mostly on the base, or the edge may be a thing. And you can see how these parameters can vary over time. You keep accumulating several parameters over time with the aging, I would say, of the transcatheter heart valves. Similarly, when we talk now about the valve thrombosis, you also have to realize that it also comes in stages, and the definition can also vary according how certain you are or according how uncertain you are. And the higher certainty, if it's occurring in the beginning, the subacute phase ends at about 3 months. And you also may have a very late stage, and whether this now becomes a little bit more panas related and not so much about valve related, valve thrombus related, that is debatable. What's the incidence of this phenomenon? At this point, we know that the incidence is about in the 10 to 15% range for multiple series. One of them is here, because the 12% was the exact number in this particular series. And the overall, you can see, falls for multiple studies, although there's some outliers, particularly the original. Why is that? Because originally, only the people who had a super high level of suspicion were imaged. So you had a skewed understanding of what's happening. When this was first reported, everybody thought that this may be more frequent than it actually was. But when you decrease the threshold for imaging, you can gravitate into subsequent studies, being all of them in the 15% rather than in the 50% range, which is more realistic, I would say, at this time. There is even a meta-analysis of outcomes of this situation regarding what really happens about this leaflet thrombosis and what mostly happens in TIAs. That's really what mostly happens. And if you, obviously, for statistical reason, combine that with minor CVAs, you can say that you're sure the combined endpoint of minor CVA plus TIA seems to be the one that is mostly affected. But the bulk of the events is mostly a TIA. And you can see some of that here. And you can see more clear event with a TIA, less clear event with a CVA. The way this may go and what may be associated now is a question of what can happen in the low-risk population. And we're going to see more data with later in the year at TCT about the low-risk studies, dedicated CTA imaging sub-study. I'm just going to show this finding that we have from the ACC presentations this year that indicate that the valve area seem to be in this point with surgery versus TAVR, very, very similar. So I don't suspect we're going to have major differences there. We're going to see about that about that population later on. And what was presented by Dr. Mack this year, that most of the time what this came about, this as a clinical phenomenon, it was mostly an asymptomatic finding that was somehow scanned and figured out. So they did not have any symptomatic valve thrombosis in either group in this low-risk population. And perhaps in the low-risk patients, some of these pathologic phenomena, they're not that aggressive, and therefore that's why they don't have that much valve thrombosis. What are the predictors of this phenomenon? Again, there was something came up in the statistical aspect. But again, who is going to really understand age? Or, I guess age, what can we do about that? Every patient has a certain age. What can we do? Ejection fraction, not much mileage either. Again, no anatomic clue that would help us screen these patients better from CT or CT point of view, or echo point of view. There were several images that indicate that some of these findings may actually disappear with anticoagulation over time, and the valve can become then beautiful and clean. In the end of the day, we call that the therapeutic criterion. This means that the fact that it cleared after anticoagulation proves the diagnosis was clot. So one can say that when you have this phenomenon, patient is not so symptomatic, even if the imaging diagnosis is doubtful, you may try to apply the therapeutic criterion, anticoagulate for a few months and repeat the imaging, and if whatever was there clears, may support that indeed there was some thrombosis that was treated successfully. There is a recent paper that indicates that if they measure the high gradient and then they treated with anticoagulation, the gradient went down. That's another way to assess the therapeutic criterion to verify, so to speak, your diagnosis. Again, obviously, you can see these gradients were a bit high enough. So if you get a gradient of 4, I suppose it's worth to anticoagulate for some time, as opposed to think right away that the valve failed. This is a summary slide of exactly what can happen with anticoagulation, and you can see that anticoagulation alone or in combination to no treatment or versus DAPT or versus single antiplatelet therapy always beats, and if you compare the addition of clopidogrel to aspirin, doesn't really do anything. So when you're talking about what to do about this situation, you have to talk about anticoagulation. You cannot talk about dual antiplatelet therapy, and again, this is for patients who you think have this condition. It's not for everyone routinely. Let me put it very, very clear. There is an interesting secondary analysis, pathophysiologic analysis, that actually said that the plateau reactivity in the clopidogrel was not associated with occurrences of this phenomenon. Taking it a little step further, because in the previous slide I showed you that clopidogrel doesn't really help. And the question is, could the clopidogrel not help? Not because it's not needed, but because these patients, or most patients, are resistant to clopidogrel. So that's why these guys went a step further, and not only did they measure the reactivity on clopidogrel, and therefore they proved that even those patients who have low reactivity or have nothing much to gain from that, because the high reactivity is not really predicting this phenomenon. So this doesn't seem to be more platelet driven, and why would it be? I show you that a lot of the situations around that vicinity is promoted by tissue factor and other non-platelet parameters. How do we screen them? We screen them by essentially the state-of-the-art, the CTA. And if there's a problem with that, you can try to have like a renal failure or something. You can try to image by TEE. By the regular echo, I don't think you have the imaging capacity to view that. What is the proposed algorithm? What do we do now? I cannot propose serial CTs or this and that for everyone. What I can propose is pretty much what Azim Latib and co-workers did in their paper as well. In a little bit more systematic way, you look at the echo gradients, and if you see a jump, you become suspicious. And then you can investigate it further. And if something else more comes up in this, you're now down here, you have a signal in the echo, and then you interrogate those people better, and then you can figure out the situation. If you have a thrombosis, then you can anticoagulate, and if you don't, then you just follow the patient again with another sort of imaging. These are the various trials that are investigated in this population. They were shown before. I have to say there is a lot of flavor of leaflet thrombosis possibility, prevention, and treatment in all of those. And I think ever since we heard about this phenomenon, all of a sudden, every single AFib patient out in the community with TAVR is getting anticoagulated. I know for a fact that before we knew or heard about leaflet thrombosis, many patients were just too old, too sick, this, that. They weren't anticoagulated based on clinical criteria. So right now, I think we've been a little more strict because there's all this anxiety around leaflet thrombosis as well. Galileo is coming up. It was dedicated to show the impact of leaflet thrombosis. It had nothing to do with atrial fibrillation in this study. All patients are normal sinus rhythm patients. And the study, as you heard, had unfavorable results. We're going to see later in the year the detailed results, probably in AHA, and for the sub-study results in a few hundred patients that is going to be the first CTA-driven study with two randomized therapies against each other. And probably we're going to see that maybe in London Valve or somewhere later in the year because we're not ready with this analysis early enough for the September meetings. So in summary, I'm going to say that leaflet thrombosis, 10 to 15%, that's a number you need to remember in general. There is an incidence of cerebrovascular events. What kind? Mostly TIA. Anticoagulation is the preferred treatment once your patient have it. And essentially the trick here is to suspect it and surveil for it, is not to go out and treat everybody. I don't think we had a great experience with that, and we want to find more about that later in the year. Thank you for